Hello and welcome to this video. In this video, we're going to be going through an article review where we evaluate somebody's statistical story that they're telling about a project that they implemented and the results that they found. In this video, again, I'm going to be reviewing an article, and for this, it's important to think through what we're trying to target. For me, I'm going to be looking at a couple of different things. The first thing I'm going to be looking for is a good feel of overall what are they trying to accomplish and what did they find or do they report that they found. Another thing that I'm going to be looking for is examples as to how I can tell my own statistical story, things that they did well or explained particularly succinctly or cleverly, or things that I might take a note of so that I can make sure if I'm ever writing this type of story myself, I can make sure I do the same. Last thing I might take note of are some things that were done poorly, some things that, as they're telling their statistical story, I want to make sure to avoid. Now, we look at this slightly differently when looking at it as an example of a statistical story than we do necessarily as a reader of just the article, but we'll bring in some things about just being a reader of the article too, as they relate to the statistical story. Some things might be some particularly clever methodological implementations that allow them to make particularly good or relevant clinical claims, versus some that maybe are not so good, or maybe the claims go a bit beyond what otherwise they should. So for this video, I highly encourage you to read the article first, go through and practice finding these types of things in the article. See what you can pull out. If you haven't gotten a chance to do that yet, I encourage you to pause this video or close this and come back to it, and then go do that so that you can come back to it with that context. I'm not going to be reading the article verbatim, though we will be going through it pretty thoroughly, so it's going to be handy if you already have looked through this. It's also going to be handy if you've tried this yourself so that you can see some places that maybe you and I are different. Now, this is all perspective. There's no right answer here. So don't be alarmed if the things that you pull out as good or bad or ugly are different than the things I talk about. What I do encourage you to do is consider how they relate back to the statistical story, and consider, again, what's good about them, what's bad about them, as it relates within that context. So, for instance, if you notice a flawed section, consider why is that a flaw? And if we discuss it here, I'll try to expound on that as I look through these things and take some time to discuss that. But as you look through it yourself, you might find things that are very different from me. Again, that's okay, but do take the time to take that final step of considering not just what do you like or dislike, but what is it contributing and how, or what is it missing and how does that relate? You'll notice that with some flaws that I think we'll end up talking about today in the video, I have my my annotated manuscript. I've been reading through it just now and writing it up, and it's got quite a few comments on there. So we'll talk through some of these. But what you'll note is in some of these discussions or comments, they relate in different ways. Some things might be relevant to the statistical story in that it was particularly well done and maybe eliminates a potential alternate explanation. Some other things might be things that are particularly poorly done and may invite alternate explanation onto the final results. We may also see some things that aren't really methodologically wrong or right, but maybe were described in a bit of a confusing way. So that is, it doesn't really contextualize the results or not, and we don't really assess it on those grounds. We just say, hey, I think you could have said this a little bit better. Or, hey, you said this particularly well, again, even if it's not a methodological contribution or component. In any case, without further ado, let's go on and jump into this article. Okay, so I've got the article pulled up. Again, if you don't have this, I encourage you to go on, grab a copy here. Reading through musculoskeletal imaging for low back pain and direct access physical therapy compared to primary care, an observational study. And actually, even within this title, observational study, I can go on and see this is going to be a study that, well, is observational. Recall in class we talked about observational studies and we talked about what that implies regarding the conclusions that we can draw. Within an observational study, we're probably not going to be able to draw causal claims, just relationships. And it's an important thing to keep in mind at the early stage so that we can come back to this when we get to the conclusions and say, hey, did you make any causal claims within conclusions, or were you appropriately contextualizing your claims as it related to this observational study design? So skimming through, there's some background here. Primary purpose of the study is compare rates of compliance. Okay, so this is good. This is what we're primarily comparing. This is our outcome variable, rates of compliance. HEDIS recommendations. This is kind of interesting. So if you're not familiar with HEDIS, I encourage you to check it out. I assume most students in this class are. But this is a data set in essence. Which kind of explicitly does not make clinical recommendations. In fact, I think on the HEDIS website, they kind of have an explicit exclusionary statement to say we do not make recommendations for clinical practice, etc. So this is an interesting start. But the NCQA does put out this HEDIS data set. And it does have methods, it does have measures involved with it. But it does, I believe, intentionally stop short of making specific recommendations. They just make reporting. On the other hand, in terms of low back pain, they do recommend, or they do mark off the amount of low back pain imaging, and I'm assuming that's what we're going to be studying here. Okay, between physical therapists, all right, that's group A, and primary care. So we've got PCP and PTs. We're looking in the context of young athletic patients. This is also good to know. We're studying low back pain. That's fine. So we've got our outcome, rates of compliance and imaging for low back pain. We've got group A, PT, group B, PCP. And we're doing this all within the context of young athletic patients. See some details in the methods here. We're going to get into this more in depth in just a moment. See some details in the results. We'll get into that more in just a moment too. So we'll step away and again come back. But note, actually, and we can real quick check conclusions. Physical therapy, we're significantly more likely to adhere to guidelines. Okay, so I'm going to ask you, do you think that sounds causal? This is an observational study. PTs are more likely than PCPs to adhere to guidelines for low back pain. That's a big claim. That's a big claim. And to me, that starts to sound causal. What's the problem here? And again, recall what the experiment contributed to our study design. What we said was in an experiment, we said in broader research, there's a lot of different kinds of studies that we can have, or a lot of different kinds of patients, and that sometimes just by chance, certain patients go to one place, certain patients go to another, so the patient groups that we're comparing are different. Which means that if I compare group A to group B, and I put a name, I'll call it PT versus PCP about who they saw. If it's just the patient groups that were different, that would have nothing at all to do with who they saw. It's just the patient groups that were different. Randomization allows us to remove that the patient groups are just different explanation, which is a pretty severe threat in an observational study. And come at this from okay, well, it's just the provider that was different. So here in this statistical story, we're doing observational data. So we're going to do, when we do this appropriately, use claims like relationships. We observed that this pattern was there. And again, we're not going to say PT did this better than PCP or vice versa. We're just going to say they were associated with better care or more correct care. In this case, we're looking at rates of compliance. So here in the article, when we're looking at this PT is adhering to guidelines better. Oh man, that's an interesting thing. It's close because adhere to guidelines, well, it doesn't really matter what kind of patients you have, you should adhere to guidelines, but it also really depends on the operationalization of this. Could this be that we're just seeing very different patients in each group? And we're talking about the percentage of time imaging's ordered. A lot of this depends on how this data is collected. And oftentimes my understanding is within this data set, there is not, and I'm, for full disclosure, I've never worked with the low back pain component of this data set, so I'm not the expert in this. But my understanding of this is that this is a pretty broad measure. That's why it's not used for clinical measurement. And I should be careful when I say not used for clinical measurement, not used for the clinical diagnosis, I should say. And you know, caveat there regarding HEDIS, and you can go and read their data sets. They've got a big page of fine print. Check that out. The front page of fine print, the very first one, is going to tell you all this stuff on them. But within that context, if it's not really particularly precisely measuring the appropriate guidelines, and again, HEDIS is explicitly not medical guidelines, then this could very well be the difference between the types of patients that are going to PT and PCP. And another question you have to ask yourself here is, do the same types of patients go to PT and PCP? And the answer is probably not. So we'll investigate that. But there are some open questions here with this statistical story. There's a couple of components that are just not quite lining up. And again, I'm not going to sit here and say good or bad. I do want to point these things out as we read through, because these are things to talk about, and these are ways that we implement this within our article review. These are things that I expect you to question and you to find when you read these studies. So I will mention, before we jump into the full manuscript, what I'll call a note of mercy. That is, you know, we're going to talk about some details in here. You can always nitpick, and for me, this is a little bit more than nitpicking. This is actually, again, kind of important, because if we have different samples, that could have a big difference on how we treat the different types of patients. But just remember, you can always nitpick. No study is ever perfect. What we're trying to figure out here is not just nitpicky stuff. It's to figure out, is this something that is, you know, just the author missed this, or it's just a publication issue, you know, there's page limit issues, etc. Or is this, and it doesn't particularly matter, or is this something that actually has an impact on our interpretation of the findings? I definitely think you should identify the flaws in studies you read and reports you read. And I think that's important because you want to contextualize your interpretation appropriately, but don't judge too harshly the people who write this, because remember, it might be your paper next that's reviewed by some class someday. Yeah, so there's always problems, there's always good things too. We'll keep diving in. All right, so jumping in, prevalence of low back pain. I thought this was kind of interesting. It's 18 to 65%. That's quite the wide range. So here, and I'll just broad strokes mention kind of what we're doing within the statistical story. Here we're trying to provide some context and trying to provide some importance. You know, $600 billion in diagnostic imaging. Of course, it's important to realize these are not all for low back pain, but they're just trying to say, hey, look, this is a lot of money, and this is an important thing. All right, so again, I kind of have an idea of where we're going because I went ahead and read that abstract there. Imaging order in a patient with low back pain in the absence of red flags. Hey, that's a place we might be different, with 28 days of symptom onset as unnecessary. And again, this is a particular measurement data set, and they do have specific measures, but they don't make the claim that those are clinically relevant in any way. So at some point, we have to, as professionals, say, hey, is the way that they measure this relevant? And that's a key argument throughout this paper that they kind of miss in a way. If everybody's on board that, yeah, that's fine, then this is good. But if we can say, hey, there are some cases that meet this definition technically, but we really should have ordered imaging, that really collapses a lot of their argument here. And that's important to consider as we move forward. All right, so again, speaking to importance, they're saying 20 to 30% of patients with low back pain have unnecessary imaging. You know, it might be something where really 20 to 30%. Oh, here we go. The 72% to 76% is the HEDIS score for low back pain, and this is just the percent of time that you did the, quote, right thing, according to the HEDIS measure. That is, you didn't assign the imaging in the absence of red flags. So 72 to 76% of the time. And if you want more details on this, is another cool part about academic research. They always do, or always should, cite their sources. So I can go down to source number 12 and get some more information on that particular statistic if I'm interested to figure out what they did there. All right, so scrolling down here, blah, 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 evidence-based, physical therapy. Okay, this will be something that comes up. I work a lot with PTs. I will say PT has a fight, and I should say I work a lot with PTs professionally. PT always has a fight to kind of justify their existence a little bit. So we'll see what this turns into, but it's probably more than they should, I think, but sometimes that comes out a little bit in their research. All right, 2-year retrospective, 83 were considered appropriate. No adverse events in over 1,000 imaging studies ordered by medical therapists. That's quite a bit. That's quite a bit. I'm kind of curious. Like, this is, hey, number 15. Maybe I should go look at that. Interesting. No adverse events. Now, it's important to wonder, what do you consider an adverse event? We're talking about the assigning radiology in a case where it shouldn't happen. Maybe that's an adverse event, but maybe not. So, all right. Early access reduces imaging, lowers costs. Okay, so we have some evidence that this might be effective. PT might do this, again, providing context, providing a series of importance. Why is this question even worth asking is what they're addressing here. In our statistical story, this is an important thing to account for. Y'all, you're not going to have necessarily 18 citations for an internal report. On the other hand, should you provide some background on the importance of the questions so that your readers can understand why we're doing this, especially if they're unfamiliar with the broader question? Yeah, you probably should. Should you also provide some initial evidence as to why you think this is going to be an appropriate intervention? Yeah, you probably should. So notice that while in this academic article, and of course, if you write or eventually consume academic articles, this is going to be especially useful. But notice in this academic article, we're still finding things that are useful, that the flow of the statistical story is still important. All right, best part. Okay, so the purpose of the study. Great. So this is the purpose of the study. Fantastic. So I'll highlight this. This is really good to acknowledge. This is what my main goal is. They have their hypotheses. Now, I will mention that the hypotheses that they discuss here are usually not the null hypothesis. These are usually the alternative hypothesis or just general questions. So here they're hypothesizing that HEDIS compliance is greater in PT than PCPs. And again, compliance is a very weird word here for HEDIS, to me anyway. That's a very weird way to say that. All right, secondary objectives. So these are like lesser research questions, but still things they're looking at. Imaging, compare abnormal findings. And again, it was hypothesized. This is kind of general hypotheses, the alternate hypotheses, I guess you could say. And think of it, to think about why these are the alternate hypotheses, consider these individuals want the data to tell them what they are finding. So they want to go into a study by default and then have the data say, hey, this is what's going on. They don't want to go in with their assumption and then confirm their assumption. They want to go in giving the benefit of the doubt to the other argument. Oh, well, we'll give you the benefit of the doubt and then have the data prove, oh, no. And again, I shouldn't say data prove, data never prove, data provide evidence for, but have the data provide evidence for the fact that PTs do better than PCPs at this. So again, they're going to walk in with the default argument of, oh, well, we'll give you the benefit of the doubt so that data can push in the direction that they're hypothesizing here. So again, here they're doing their alternate hypotheses as opposed to their null hypotheses. But that's what's going on, and that's why we tend to set up studies in that way. All right, retrospective cohort study conducted at Keller Army Community Hospital. Interesting. USMA West Point. Okay, did they say this in their up here? Did they talk about that this was the context? That this is only in medical, or excuse me, only in military? We'll see this up here. So this is a massive. So again, our cool part about statistics is that we can take data from a sample and use it to represent a broad population. But we had this caveat. The caveat was we represent the data, the results apply to the people represented by the sample. Not to everybody, not to everybody in the whole world. They apply to the population that's represented by the sample. Now, in this case, it looks like our sample is coming only from military institutions, which may or may not be fine depending on how you define this. But consider that if there's even a question, that really limits who the population is that this sample represents. In this particular case, that population is going to be not the United States, not even young adults in the United States. And the other interesting thing is they're not explicitly saying they're studying this, but it's not the PTs or PCPs in the United States. So it's not the sample, but it's also not the practitioners. This is military, and again, is going to connect with military. But this is something that they're probably going to need to mention and really contextualize their results with. All right. So PT possess clinical privileges, so they can give some limited medications. Good to know. I didn't notice that the first time. That'll come out later as we read through this. Patient range was restricted 18 to 24-year-old. This patient range was selected to allow comparison between the physical therapy and primary care. So this is actually important. They are trying to make these groups more and more comparable. One claim might be, hey, PT sees younger patients than PCPs in the primary care clinic. And so they are trying to eliminate that alternate explanation by making these as comparable as possible. All right, so I'm going to keep scrolling down here. We have, all right, so they're getting data. Clinic evaluates numerous and non-cadets. Okay, that's kind of interesting too. Do they say that they're all cadets? Huh. Didn't notice that, but this part's kind of interesting too. So the clinic may have non-cadets as part of the clinic. So they, again, this is all going to what could cause people in group A, the PCPs, to be different than the patients that PCPs see, to be different than the people in group B, the patients that PTs see. And if there's a big difference between these groups, then is that the explanation of what's going on here as opposed to PT versus PCPs? All right, so we're studying this from January 19 to May 2020. This is a potential interesting thing as well. Maybe, May 2020. I don't know if you'll notice, but something happened in 2020 that we might want to account for here. I'm surprised they didn't make this March 2020 because I'm assuming, again, a primary care clinic in 2020. Man, this. Anyway, I wonder if they should have instead done maybe March of 2020 or even earlier, January of 2020, before COVID became a thing. But yeah, January to January would have made more sense to me here. Even if you had access to more data, the introduction of how does COVID play a role at a primary care clinic versus at a physical therapy clinic, and does it play a differential role in those two places? I mean, the answer is frankly yes. So those are now all baked in the cake of how these groups are different. All right, so here they go. HEDIS measure. This is the appropriate way to identify it. This is a HEDIS measure. It's not a standard. It's a measure. An imaging study, first encounter, low back pain, 28 days. Of course, there's the whole red flag thing too. Figure 1. Oh yeah. For the record, we typically put equations into papers as equations, not figures, but we'll let that go. All right, cases are excluded. Perfect. So there's a lot of different exclusion criterion here. That's where they're talking about their I assume what they're using in this study, or is this the HEDIS exclusion for low back pain? I can help. I'm not quite sure. High rate reflects better performance on HEDIS. That's correct. HEDIS measure. Again, guideline, no. Measure, yes. Calculation, yes. Guideline, no. No, probably not. Low back pain. Yes. Yes. Yes, you have to exclude. So I'm still not sure. Was this done here? I hope it was done here because that needs to be done here. There's exclusionary criterion that's not included in HEDIS. Or maybe they're just pulling the HEDIS data set. I mean, they're using the HEDIS measure, but could you manually collect the HEDIS measure? Yeah, I'm assuming you could. All right, so in-depth review, low back pain, IPAX was used 2014 to June 2020. Huh. I have questions. So yeah, 2014, 2019, which one are you doing? Aside from this, and we actually will find out. I don't want to hide it from you. That this one up there for two different outcomes. They're doing this for one set of outcomes, and this for another set of outcomes, and they're not using the same data set. They're using two different data sets here. But note the confusion in the story. It's not really particularly well explained here. It's actually not really explained at all as far as I'm concerned. So note the confusion in the story that goes on here. It is pretty confusing. It is pretty not straightforward. So that's probably not so good. Not so good. And again, June 2020. Very interesting that we're continuing to look at 2020. All were independently reviewed by one of the groups we're comparing. The one who we're going to try to show is better. This is interesting. It's not necessarily bad to have you and your group review something. On the other hand, this is something that I always make a note of, because if ever there's like decisions that need to be made in a study, and everybody who's running the study comes from one side of the coin, sometimes I don't trust that the decisions were made in a way that was equitable to the perspectives on both sides. Again, it's not always possible to avoid, and it is actually good that they say this explicitly so that we as the reader know to take their decisions with a grain of salt, as they're probably going to lean towards the PT evidence more than the PCP evidence. But it is good to, it's something we need to acknowledge as a reader. You know, we can respect and appreciate they put it in. On the other hand, we still have to say, yeah, if there's any questionable decisions, let's see which direction they fall in. And if we start to see more decisions than not fall into the PT bucket, then we might look at these researchers and say, hey, look, it looks like all of the researchers are physical therapists, so maybe they're going to have a story that they want to tell. Patient documentations were de-identified and then assessed. Well, this is kind of what we're talking about. Hey, now we're doing some assessment. We're doing assessment of PTs and PCPs, but we don't have any PCPs doing assessments. We just have PTs doing assessments. All right, so going down here. If a provider's note did not explicitly state the duration of symptoms, period of 7 days was input for acute. Huh. Okay. This is a bit of an interesting decision. This is kind of completely arbitrary, and maybe somebody knows, and if so, in your journal, write a comment so that I know. Maybe somebody knows a reason why this is done this way, but to just make up a number of days that an individual has had symptoms. Now, eventually they're going to do a calculation where they average all this together, which is why I believe they need the numbers here. But to just make that up to be something, I mean, to me, it would make a lot more sense to, if it doesn't actually mention the length of symptoms, not include that patient in a calculation of length of symptoms. Or if we have access to the charts that we're pulling the reviews from, go in and see if we can dig a little bit deeper. Yeah, that's an interesting decision too. Ultimately, what this means is when we're looking at any variable that's the number of days, we're going to be a little bit careful about that explicitly, because it's going to be biased towards 7, 30, 90. Those numbers and values here. Variables of interest: number of visits, amount of time from initial physical therapy evaluation. I assume this is a typo. I don't know. Would you call a PCP visit an initial PT evaluation? I'd assume you wouldn't, but if so, that means they're either A, just looking at physical therapy here, which is a weird decision, or B, this is just poorly explained and we need to dive more in depth. All right, so continuing on, let's see, we have that abnormal findings were considered not clinically significant, or excuse me, abnormal findings were considered clinically significant when it altered the plan of care or affected prognosis. Now, this makes sense, I think. Looking at this, what I find weird about this is that later on they talk about abnormal findings here. At first, I had thought these were just examples of what they're looking for, but I'm wondering if they actually went through and diagnosed this. So I'm wondering if It's not whether it altered the plan of care, as in they have a chart record that says this finding altered plan of care. I'm wondering if it's these physical therapists saying, hey, it should have offered plans of care. And so I had initially thought this was the definition, and these were some examples. But looking through, again, it says stuff like this throughout, but that the people met to review any differences in radiographic findings, and that just doesn't seem to really make a ton of sense to me. So I'm not quite sure what's going on there, but it's something to definitely keep in mind. Statistical analyses were performed in SPSS. We have alpha equals 0.05 set a priori. You're starting to recognize some of these things, what these mean. This is my type 1 error rate, 5% type 1 error rate. A priori means this was set before the study was conducted, which is good. Statistical analyses were performed in the software. This is something that we often do, is report what software statistical analyses were performed in, though. Like if you're doing something in Excel or by hand, it's not completely necessary, but it is something that we do. Descriptive statistics were calculated. Okay, so this is good. Where are they using descriptive statistics in their story? So we've got demographic, imaging, significant findings, specialist referrals, and interventions used. So these are things, again, we know what descriptive statistics means. This is saying we're kind of describing what happened, describing the sample. And one of the purposes in the story that we'd be describing the sample for is to determine who does this sample then apply to. So where can these results apply? Chi-square tests were used for categorical variables, so this is probably why Dr. Florence making us read this dumb article in the first place. T-tests were planned for all continuous variables. So this is where we're talking about the types of tests that we're going to run. T-test is like in our Foundations of Inferential Statistics lecture, kind of what we were doing. We haven't talked about this. We'll talk about the more generic form of ANOVA later on in the class. But that's all that's going on here. This is very similar to what we did with the Z distribution, just with that T distribution. And again, we talked about that in the Foundations of Inferential Statistics lecture. So we tested the assumptions. I think we briefly mentioned assumptions with the chi-square test. It turns out that some of the assumptions, specifically the normal distribution of the data, were deemed sufficiently violated to justify the use of another test. And this is the one you'd want to use, the Mann-Whitney U-test. It's called a non-parametric test and doesn't make that normality assumption. This is beyond the scope of what you'd pull out of this article, but for me, this is something that I definitely pull out. Is they're testing assumptions, which is a good thing. They're making a correct adjustment when they're not doing assumptions. So overall, this statistics section looks pretty good. They described their error rate. They described that they're setting this a priori. They gave the software they're doing. They described what descriptives they're doing. They described what inferential statistics they're doing. They mentioned that they conducted the parametric assumptions for the inferential statistics that they're running. And again, note that this is not for chi-squared. Chi-squared doesn't have these. This is for the t-test because we're using a replacement. Mann-Whitney U as a replacement test for the t-test for differences in groups in continuous data. So overall, this is a good looking section, and this is one I might pull out as a good example of how to write this if I were implementing one later on. All right, results from January 2019 to May 2020. Okay, so I guess this is the date range that we're looking at. As we talked about before, these different date ranges, it becomes, it actually never really becomes clear in the paper, but if you put 2 and 2 together later in the paper, you can figure out this is a different data set than what they're talking about down here. For me, they never really clarified that, which was a bit irritating, but that's what's going on. We've got 1,845 total visits for physical therapy, 467 total visits in the primary clinic. LBP is lower back pain. So here, this is my margins. So recall that we had our margins in our chi-squared analysis. These are the margins. These are the total number of people who went to PT whether or not they got radiology, and the total number of people who went to their PCP, whether or not they got radiology. Encompasses only initial and reevaluations. Physical therapy treatment appointments are not included. So this is kind of an interesting point. The 1,845 and the 467 are not themselves unique participants. These are, in fact, number of visits. And you'll see this somewhat often. I don't want to say somewhat often. You'll see this occasionally when you're looking at data analyses, is that you expect the unit of analysis to be the participant or the person. But in fact, the unit of analysis and the percentages then calculated are not based on person. They're based on, well, in this case, number of visits. Here, the interesting differential there is that how do you classify number of visits? If I have a repeat visit for the same person over and over again, does that play a role? Here, recall that one of the exclusion criterion, or one of the things that they're testing for explicitly, is if they have an image within 28 days of the diagnosis. So let's say I have a patient who comes in, and I believe it's the primary diagnosis is how HEDIS defined it, is the primary diagnosis. So they come in, patient has another issue, but then they also have low back pain. And that's something we're going to keep an eye on. And then they come in 2 weeks later, or 28 days later, and have the back pain's gotten a lot worse. We sit down, we meet, we talk about what they've been doing, and they've been doing all healthy things. They've been taking care of their back. How does that play out? Well, in this particular case, depending on, again, the numerator and denominator, the number of visits, I might have one visit that has may or may not even count because it's not the primary diagnosis. The second visit might count, but it might count against me because I'm assigning imaging after this meeting instead of after the pre-meeting. So again, I'm not saying it's right or wrong. I am saying this is something I want to point out to you as we're reading through this so that you can pay attention. All of our claims now are going to need to talk about total of visits rather than patients. Repeat patient loads may skew numbers if I have skewed patients because they appear multiple times in the data set. And what I'd want to think through there is a patient who's a repeat patient more or less likely to have back pain low back pain and or more or less likely to receive imaging? And if those things could even plausibly be true, these are things that we need to consider regarding the interpretations, and again, contextualize the interpretations. So here, again, they're going on and saying outright, this is number of visits, and it's only initial and reevaluations. PT appointments are not included, and they don't really kind of say what they do with PCP appointments that are not classified under these two groups. All right, the comparison of HEDIS compliance for low back pain is shown in Table 1. So whenever I see a table, I always scroll to find it, so I know what they're talking about. Table 1's right here. I have physical therapy. I have primary care. I have HEDIS LBP. I have HEDIS LBP non-compliant. And again, compliant is, to me, a weird word. I must be missing something. Somebody in your journals, if you're familiar with this HEDIS LBP, I just can't imagine what compliance could be. Again, HEDIS explicitly says that it doesn't cover that. So I'm just really curious if any of y'all have experiences on this. And I doubt you do. Again, I think they're just phrasing this in a bit of a weird way, which sometimes people do in articles. Journal authors aren't perfect. Just because you're published, that doesn't make you infallible by any means. So in any case, we have our margins here, 1845, 467. This matches what we pointed out earlier in the article, 1845, 467, where 1845 represents the total number of physical therapy patients and 467 represents the total number of primary care patients. Here they have percentages. Percentages can be tricky in a table like this because is it the percentage of the row or percentage of the column? Here, these represent the percentages of the rows. Sometimes you'll see them represented as all three. Or could this percentage be percentage of total patients in the table? That's a third percentage you could choose to provide here. So percentages can be a little tricky. Here, this is percentage of physical therapy and percent of primary care. in a way that somewhat intuitively makes sense given the research questions. And here we're saying that in physical therapy, of the number of visits, 3.3% of the visits were deemed to be HEDIS LBP non-compliant, which I'm assuming means that they weren't measured under the HEDIS LBP listing for the classification of their measurement. And primary care was deemed to be 18%. And again, this isn't 18% of people. This isn't 18% of clinicians. This is 18% of visits were HEDIS LBP non-compliant. And again, that's just such an interesting, because later on they say they can have repeat visits. So what do you, anyway, that's just an interesting thing. I have a person who comes in 3 times in 2 weeks. And so I end up sending him for imaging. And I guess this would count as 3 non-compliant visits because they came in 3 times. Again, just an interesting potential ramifications. If they're the same for physical therapy and primary care, that doesn't impact the differentiation between physical therapy and primary care. Here we see the chi-squared is some massive number and the p-value is well below the alpha level. So this is highly statistically significant. And now we also know that we look at practical significance too. This does seem to be clinically significant. 3% versus 18% is quite a bit of distinction between compliance and non-compliance as these authors have defined it. But again, the whole thing about a patient comes in 3 times, and now if I order imaging, I have 3 dings against non-compliance. That's only relevant in the case that physical therapy and primary care have different numbers of patients who come in different amounts of times, and that the patterns of those patients would be different. So that in primary care, you may come in multiple times and need more urgent imaging that's not classified as an exclusion under HEDIS or under the HEDIS measure, and that in physical therapy, you may come in multiple times and not need imaging as classified as excluded under HEDIS. Actually, that does make sense to me, potentially. I feel like physical therapy has more repeat clients. I believe they even might mention this later in the paper. And in primary care, if you come in multiple times in the period of a couple of weeks, we might look at your case somewhat differently as to whether or not that would be classified as an exclusion under HEDIS. I believe traditionally not. We can go look at the exclusion criterion: history of cancer, trauma in the last 90 days, intravenous drug use, this particular syndrome, HIV, spinal infection, organ transplant, 90 days of corticosteroid use. So actually, that would not classify as an exclusion, what I'm describing, but may be a case where if you're the attending physician, you choose to, or excuse me, you're the primary care physician, you choose to utilize imaging due to the severity of the complaint. In any case, that would not be classified here. All that would be classified here is that those 3 visits would be out of compliance, and broadly speaking, 82% of the primary, the PCPs are in compliance. This is actually higher than the overall average. As to why that is, obviously I wouldn't know unless the authors indicate that. It could be because this is the medical institution, could be they're dealing with just young adults. I don't know. All right, so they list the chi-squared. This is a bit atypical to present a chi-squared, but that's fine. Usually you do the x-squared. Normally you give the degrees of freedom, in this case 1, then you write a little equal sign. P less than 0.001, perfect. So this is, again, not this part, but maybe this part is often how things are presented, and usually the chi-squared is presented in text, so it might be something to write down for if I'm ever writing my statistical story. It's nice to include that information there. Now they provide a little bit details about who the evaluators are, the medical evaluators. So in this case, we've got 24 physical therapists, 16 are board certified, and I guess there's just 8 who aren't. Is that right? Yeah. Okay. 16 are board certified. Okie doke. 24 care providers. There are 4 nurse practitioners, 5 PAs. Now, this is an interesting inclusion in PCPs. I guess that makes sense, but I'd be curious if these were broken out as a subgroup, if they would differ from MDDO. So 10 board-certified physicians family practice, 2 board-certified in internal medicine, 1 pediatrics, 1 obstetrician. Oh, that's kind of interesting. And 1 general practitioner who is the only one they don't say board-certified for, so I'm going to assume that this person is not board-certified. So kind of an interesting breakdown of these individuals. I'm thinking through, to me, it would make sense to do NPs and PAs as a distinct group. It also makes sense to take your 8 non-board certified PTs. That's kind of an interesting thing, but it makes sense to treat them slightly separately too. All right. So now they're talking about the second data. So we've got this June 2014 to June 2024 data that we're going to be looking at. Okay, so we got 94 cases for PT, 106 cases in PCP, 2 cases ordered, and 56 cases ordered were 2 cases were ordered by PTs and 56 cases ordered by PCPs were excluded. Well, that's kind of interesting. You exclude more than half of the PCP cases? 92, yeah, include 50 PCP, 56 were excluded. Listed in figure 2, okay. So this is kind of interesting too. Now, later on in the paper, they'll explain, and the explanations may seem reasonable, but it's important to realize these explanations are not for this first analysis. It's a bit tricky when working with 2 data sets because these 2 data sets are different. If you're going to exclude these cases, I'm assuming you're excluding for a good reason. But that means that 50% of your PCP cases up here probably should be excluded under whatever classification you're excluding them down here. So the fact that you're only excluding them in one of your analyses, not the other, is pretty weird. Also, the fact that you're pulling out more than half of the cases is pretty interesting. They go on to explain. 20 were initially seen by a PT. Okay, so 20% of the time, the patient initially sees a PT and then goes to PCP. 20% of the time, patient initially sees PT. And again, this is 20, but their original number was 106. 20 over 106 is close to 20%. 20% of the time, you get a PT, then you go to PCP. I'm assuming that's true here too. It's kind of an interesting, man, it is an interesting combination. And of course, if this is the case, that might change your approach. Now, the 28 days was from initial diagnosis. Is this initial diagnosis with that current provider? So what if PT was having a tough time with the low back pain? Of course, something had to have happened if they've been seen before on this, and then again, provider ordered imaging. Like that makes sense. But again, that's 20% of the cases that's not accounted for here. 20% of our 467 is, I don't know, just a little back of the envelope math, about 90. That could account for 90 of the non-compliant cases here that are being removed, rightfully so. So this is, I mean, if this is the case, and this reflects an underlying trend with the type of LBPs that primary care is seeing and what they're ordering imaging for, that's kind of a tough argument within this data set. Because that might be a lot of those non-compliant issues that actually, once we factor that information out, would then be compliant. So it's an interesting, that's a very interesting pull. Demographics in table 2. So again, we look at demographics, we compare. Okay, so the ages seem relatively comparable, 20.3 to 20.7, both in the low 20s, both just above 20 years old. Sex, female. Okay, so we're seeing more females in physical therapy than primary care. That's interesting. Not statistically significant. So I'm not gonna really think too much or read too much into that. The reason that this difference, it's 11%, is not statistically significant is likely because of a sample size. Well, ultimately, it's all because of a sample size issue. With the same percentage difference and a higher sample size, we would definitely find a statistically significant difference. All right, looking through here, I'm just going to glance quickly at the significances. Okay, this one's the only one that looks close. Looks like we have more hip-thigh issues in physical therapy than we do in primary care. Below the knee more, coccyx more. So these are all, I mean, it's looking like everything except lumbar is higher in PT than it is in primary care. And again, these tests individually aren't statistically significant, but they don't actually perform a joint test of all three of these. Looking at these, this is 15%, this is 8%, this is another 15%. Those seem reasonably higher. This one, well, this table looks a bit off scope here, but I believe this top column is duration of symptoms, or excuse me, top row. They discuss this in text, but this is one other contextual thing. And again, this is what happens when we do observational designs. This is a big problem with observational designs, is our groups are not necessarily comparable to start with. So in this case, again, first of all, you're excluding more than 50% of physician cases for some reason, and we'll go more in depth, or the paper goes more in depth on that further below. But it's important to realize they're not doing that for this first test. This test where they have this massive chi-squared, they didn't perform this exclusion, and they don't describe if the data set they're using pre-does this. So I'm going to assume that it doesn't. But they, again, for some reason, they feel that this many cases need to be excluded. So it's a bit difficult to really trust these results for me at this point, because again, you excluded more than 50% of cases. I assume you did that for a reason, but it seems like you did not do this with the initial this other data set. So I have trouble trusting the other data set. Additionally, though, in the data set, even when you excluded all those cases, your primary care has a history of more than 3 months more on average back pain than your physical therapy patient. So your PCP comes in, and we have 212 days. Now, I'm not a mathematician, but I'm going to guess it's around 7 months of back pain. And here, 104 days, we're looking at about 3.5 months of back pain. So here, we've got massive differences in the length of the symptoms. And I say back pain, it looks like there's multiple different kinds of pains they present with. In fact, this is kind of interesting. Low back pain, below the knee. In a study, okay, so this is lumbar spine imaging orders, but this isn't actually low back pain, I'm assuming, because of the 92 participants, only 72 had painful lumbar regions. Now, looking at these numbers, they add up to more than 92, so we're having some patients complain of pain in multiple areas, but it's kind of interesting that again, we're doing lumbar spine imaging orders when there's not back pain in the physical therapy group. In the primary care group, it looks like that's happening a little bit too, but it looks like that's happening less often, not statistically less. In any case, so I said back pain earlier, so I should just say pain, apparently. Looks like we've been having these symptoms for almost double the length of time, for more than double the length of time. 3.5 months versus 7 months. That's quite a bit different. Now, that's not statistically significant. The reason we're seeing this is there's a high standard deviation, and now we know the difference between standard deviation and standard error. There's a very high standard deviation here. So there's a high variability going on. But even, I mean, and that's important to know. That's why that's not going to be statistically significant, plus the sample size. On the other hand, this is pretty different. This is very clinically significantly different, at least from my perspectives on this study and the relevant factors relating to these issues. And again, that's an interesting thing to mention too. It's a bit of an aside, but depending on who you are and what your beliefs are, it could be that some of these factors mean more or less to you. than they do to me. Anyway, looking through this, acute doesn't seem like there's much of a difference in the percentage of acute. Here's interesting, subacute, we have less of that in the PCPs than with the physical therapy, but chronic, oh, excuse me, am I reading this incorrectly? Oh, no, here we go. Chronic, we have a lot more chronic that PCPs are seeing than physical therapy. So that's kind of interesting too. And again, it's important to realize our samples are not comparable. These differences that we're noting here, even the ones that aren't statistically significant, they don't have to be statistically significant to impact the study. The goal of testing significance is to say the statistically significant ones are definitely there. These ones may or may not be there. Ultimately, we don't have enough evidence to conclude that they are. Oh man, that's close. Again, shades of gray evidence, shades of evidence, all of these shades of evidence. Surely God loves P of 0.06 nearly as much as 0.05. So taking all this together, it looks like there might be some differences between our primary care sample and our physical therapy sample. And again, this was the concern we were saying about observational studies. Is it bad? Well, I was going to say absolutely not. It just means we have to contextualize our claims. It means that we can't and shouldn't make causal claims. Our study is not designed in that way. So it just moderates our claims a little bit. More than it's bad. It's certainly not morally bad or morally wrong. We just want to make sure that when we're discussing our claims, we are doing so from the acknowledgement that our samples could have started differently, and that may have caused the differences in the outcome. So we're going to see textual summaries of the information that's in the table, depending on the journal. They don't like you to do this, but that's fine. I thought this one was interesting. I believe this is in a different table. Here's the diagnostic imaging, table 3, and then table 4. So this is the types of imaging that we're doing. I believe we have, this is our X-ray, our MRI, and then whether or not there were clinically significant findings. They're not finding a lot of statistically significant differences here, but again, you look at this 31% versus 20%. Those effect sizes, it's tough because, again, it's not statistically significant. To me, I think I mentioned in our class videos, when it's not statistically significant, you shouldn't even look at the effect sizes. That's maybe a classic perspective, but here we've got a 30% difference in abnormal MRI findings. Ooh, but a sample size of 12. Okay, so this one I don't trust as much because with a sample size of 12, that's extremely variable. But with this one, a sample size of 50 versus sample size of 92, 11%, like this, there's just not enough evidence to conclude it's actually there in the population, but this is one I definitely keep out for in a future study to see, hey, is this there in future populations? Could be. Yeah, this one, it's tough with 12 because you think, well, hey, what if you just have one more participant? That might change this ratio quite a bit. Adding one more positive participant here, 8 instead of 7 out of 12 would jump this to, well, 8 over 12 is, let's see, 2 over 3, so that'd be 66.6, 67%. You'd jump almost 10% by a single participant being different, and that's why this is tough to bet the farm on in terms of the difference. But anyway, we've got table 3, we've got table 4 down here too. The patterns of care. This is interesting. Visits between evaluation. Things to talk about. These videos are getting pretty long here. I apologize, or this video, excuse me, is getting pretty long here. So I'm going to not jump into all of the details. Primary care, referred patients to physical therapy, or ordered drugs. Actually, this one, so this was interesting. If we go down to table 4, the most common approach with PCP with this type is to refer to physical therapy. And this was kind of one of the interesting components. They could assign drugs. I was curious if they did this concurrently. They don't actually break that down, whether or not they refer to physical therapy concurrently with assigning drugs. They assign drugs in place of the physical therapy referral. At least some of these have to happen at the same time. presumably, unless all the drugs are all happening at the same time. I guess that could be too. Oh, no, 25 out of 50 to 28 out of 50. There must be at least 3 overlaps, but potentially as many as 25 overlaps. All of the people who were given NSAIDs were also referred to physical therapy, and they don't break that down. So I feel like that would have been an interesting statistic to look at, is what are physicians doing? And it seems like, hey, maybe a lot of them are referring to physical therapy. All right, so let's start breaking this down. We see again the excluded cases. It's fascinating to me. We've got 20 people were excluded because out of 100, again about 20%, because they went to PT and then went to their PCP, and that doesn't happen with physical therapy. We don't have the number who went to their PCP and then went to PT. I mean, presumably because most people do that. I actually don't know. Again, it's something they don't discuss and is potentially worthy of discussion, but these don't match the HEDIS exclusions, at least not by default, not the ones that they list. So it's very interesting. It's very interesting that these are included. Again, these to me make sense. We're doing a physical. We're ruling out a spine in a different diagnosis. We're doing a spinal surgery. Like all of these seem to make sense. And actually the ones I was expecting before reading the study was not in electronic health records. So these are exclusions because we just didn't have the records for them. But some of these were, again, they make sense, but are a little bit surprising, and ultimately, again, have this massive reduction of the sample, and ultimately, again, make it questionable. The sample doesn't necessarily seem comparable to that HEDIS data set because they have lots more exclusions here. All right. Let's see, looking through here. Less likely to diagnose. Yeah, this is, man, I struggle with this. You know, kind of what's the takeaway? They're going to talk through here, I'm sure, about how PT is just way better than PCPs are. Yeah, here we go, compared with the 82% of primary care providers. In this study, we restricted the range of available encounters. So it's good that they're, you know, talking about this, but again, it's, man, it's something that, you know, you've kind of controlled for one comparison, but you haven't really controlled for the rest. And again, this is an observational study. So it's good that you did this, but it's still an observational study. You actually have statistically significant differences between your group up here. That doesn't mean you can't make any claims at all. It just means you have to kind of be careful the claims you make. Oh man, my eye just glanced on this statistic. No PT prescribed acetaminophen or ordered acetaminophen. That's kind of interesting to me. Again, I think there's reasons, but like 10% of PCPs did. Like, I just, you know, it makes you ask some questions. Like, what is going on here? I am glad they did say in the early area of the study that they do have the authority on base to prescribe medications. So that's an important thing. But again, there were some PTs that were not licensed, right, or not board certified. Gosh, where did it mention the certification of the? Here we go. 24, yeah, board certified. There were 8, 1/3 of the PTs were not board certified. So I'm curious if PTs who are not board certified could assign medication. Could that be an explanation? Excuse me, it's this table down here. Could that be an explanation? One more. Could that be an explanation of the difference in medications ordered? Is that literally 1/3 of the PTs did not have the authority to prescribe medication? And so that's kind of an interesting thing. And again, as it goes back to the statistical story, and I want to keep tying this back because I feel like I'm just talking about the study. which is important. And this is what I want you to do: is think through critically the studies. Don't be mean. Again, people are trying their best, but be critical consumers of research and of reports. This doesn't just apply to some random published study on low back pain. This applies to any report your data team may present to you. Really think about it. Really think through, hey, is there another way to think about this? I liked this alternate explanation as a potential limitation, like could reflect just greater access to physical therapists. They say, oh no, because the imaging order time would be longer. On the other hand, the wait time to get into a PCP is not necessarily the wait time to get in with radiology, so that doesn't quite line up, at least to me. As I talk about the cases of spinal manipulation, etc., that does make sense to me, that that's happening more often in PT. And then they talk about, I mean, this is something I mentioned earlier and was one of the first things I saw with this study. I was glad they ended up talking about it, is that this difference in the duration of the symptoms between PT and PCP is much larger. And again, even taking this explicit statistic aside, think about what this could mean. There's just different types of people experiencing different types of issues within the two groups that might not, we looked at a lot of things in this study, or they looked at a lot of things in the study, but they just might not have asked the right question as to what's really the difference between these. And this is a pretty big freaking difference. So, again, you're forced to ask, do we just have different types of patients in different groups? Now, in addition to that general question, does this represent different types of patients? This specific question of these days versus each other might itself be evidence within imaging decision. And that's kind of what they argue here. Again, they use HEDIS standard, which I just really don't like. But they point out that their measurement, the HEDIS measure, does not distinguish. Now, they kind of use this to justify that they shouldn't have to care. On the other hand, this might be good evidence that maybe HEDIS is not the best measure here because it doesn't distinguish. And so if you have a patient who's coming in with 7 or 8 months of back pain and you say, gosh, hey, maybe we should get that looked at, or maybe we need an image to make sure nothing more serious is going on, it's interesting that HEDIS marks that down as an improper decision, improper medical decision. And again, in the defense of HEDIS, they do not claim to be the medical standard of care. They explicitly lawyer up against that. On the other hand, this paper is using it as that. So when they're using this HEDIS measure as their standard, it invites some questions as to, is HEDIS a good standard or not? And again, if it's not, it kind of undermines their whole claim. If it is, then, okay, well, this doesn't really mean anything. And the problem with their argument here is if this were statistically significant, they could still make this argument. If this were 100 days to 1,000 days of pain, they could still make this argument. Again, it's kind of a problem that HEDIS doesn't really care about how long you've been hurting. It just cares how long from the, quote, initial diagnosis. And again, they don't, at least as I remember seeing, they don't actually formally define that. They kind of refer you back to the HEDIS measure. And again, HEDIS is well measured. It's just not a standard of care. It's just not standard of care. Okay. Following the distribution of pain in different. I didn't really follow this one, to be honest with you. I wasn't sure. I wasn't sure what that meant. Oh yeah, here the red flags. Persistent pain. Again, this is the HEDIS exclusion criterion. So it's interesting to me, like a red flag or persistent pain following 6 weeks. Like, is this not something that maybe is more likely with somebody who's had pain long term, maybe received care from a couple of different places, but not this institution? So the initial diagnosis didn't come in. until later on, but they've been managing that care appropriately. Again, this is something that within their sample, they kind of say, hey, if you've already been seen by somebody, maybe we're going to exclude that. But in that broad sample, they don't describe doing that, and I don't believe they do. Here's when I finally figured out on my first read through they actually are treating HEDIS as a standard, and that's probably not how they should do. But as you read through this is kind of where they start concluding. So here they're talking about a couple of things. They're trying to provide some context and make it an argument, a counter argument, anticipating some people who might struggle with it. And I do respect their intent to do this. And I think this is a great lesson to take away. Again, I disagree with this argument. I think this is a large difference. I think their argument that HEDIS doesn't care is actually an argument against using HEDIS in this type of a study in the first place, the HEDIS measure. But they're at least trying to make the argument. They're acknowledging, hey, this is a large difference, and they're trying to make a convincing argument as to why they believe this study is still internally valid. And again, what I mean by internally valid is the difference really due, even within this sample, is the difference due to PT versus PCP? Versus if this is the cause, then it didn't really have to do with PT versus PCP, the provider. It had to do with the sample of patients who were in the different groups. That's what really caused the differences. Is the PCPs just had different people who, for whatever reason, were sicker or were more in need of diagnostic imaging than the PTs did. And again, I feel like as an outsider coming in, that would have been my assumption, is PCPs are maybe dealing with more issues that do require diagnostic imaging than a PT would be. And this never really contradicts that argument. But they do try. They make an attempt, and that's something to take away. The positive note here, the thing to remember from this paper, one of the things, the lesson here, the good thing here in terms of statistical storytelling, is don't just close your eyes to counter arguments. Pay attention to them and critically evaluate them. Now, to me, a more balanced evaluation might have admitted, hey, this is actually a problem, rather than explaining it away and saying, well, our measure doesn't really care, so it's fine. They might have engaged more with what this could potentially mean to the conclusions. But at the same time, they're trying. They're acknowledging the problem. They're trying to address it. And again, for us, as we've learned in class, the goal isn't to argue your point. And that's very important. As I mentioned at the beginning of this review, we're looking at several physical therapists. And I love physical therapists. I work and consult with them. I consult with them on research. I believe I'm published in 1 or 2 physical therapy journals. But in this, and I've presented at several PT conferences. But in this, I'll say sometimes PTs really try to argue that their existence is justified, and I absolutely believe that it is. Don't get me wrong. I just feel like that sometimes leads to arguments for a position, and again, using the data for support rather than for illumination. Differences like this, they are illuminating in the limitations of an observational study. And I feel like a more honest assessment of this contribution to the study would say, look, this is an observational study. This is a potential flaw in the study. But it's part and parcel of being an observational study. So in the future, we encourage other people to look at that, and hopefully you get a sample that isn't massively different in terms of how long they've been having the symptoms. So looking at this anyway, in the story, they're kind of closing up. So what is the takeaway? And so they're saying, hey, imaging privileges have been historically controversial. True. Of course, they don't cite that, but that's an academic thing. We don't need to worry about that too much in this class. This, I mean, to me, this actually makes a lot of sense. Now I see why we're doing the push and why we've got PTs running the study. They're trying to argue that they should have more imaging privileges. And ultimately, I think this study probably does lend some support to that. I mean, certainly PTs are not doing much worse than PCPs, though again, the samples are not, at least to me, they have some questions as far as comparability. Are they really the same sample? We don't have the randomized trial to assess that, and so we just have to look at our descriptives to see are they the same? And remember, they could be different on things we didn't measure. That's the worry. That's the worry, even if these weren't statistically significantly different at all. And remember, they were close. If they're close, that still means something to me. And even if they weren't different at all, the question is there something that we didn't measure that actually is different? Results are consistent with previous reports. Okay, that's fantastic. So we've got other research that says this. And I wanted to highlight this one. So this is the kind of thing that happens all the time. It happens in published research, absolutely. It happens in private reports. It happens all the time. It happens everywhere. And what this is it says widespread adoption of imaging privileges for physical therapists will ultimately enhance capabilities to manage low back pain in a direct access setting. So they're trying to make claims about people everywhere based on the sample. And this is what inferential statistics are for. But remember what we talked about at the beginning of this video and what we've been talking about with the whole thing of statistical storytelling is that there's a broader context to the story. Inferential statistics contribute to a story, and that story is in the context of the study design as described by descriptive statistics, etc. And so here, with the study design, we looked at a very, 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 very specific group. We looked at young people who were physically active on a military installation in terms of the care, and I'm assuming these are cadets. I believe one of the clinics was that the care clinic was in at West Point. And so to take results from West Point and to say, yeah, because of this, and to take physicians, Army doctors, working at West Point, and to say, hey, because of this comparison of these people, this, and again, let me go back to the language here, widespread adoption of imaging privileges, enhanced capabilities, frontline providers, like these are generic terms. These are big picture terms. And while samples do go to populations, recall the caveat of that, they go to the populations they represent. So our sample does not represent broad speaking populations necessarily. Our sample represents young, active military installations. And so I think this is a good claim for young, active individuals in military situations. But this is probably too broad of a claim for this study. In fact, it's almost certainly too broad of a claim for this study. The thing is that many times this is what you want to say in your report. You want to have a sample and you want to describe it to everybody. And again, inferential statistics, it's a little like magic. We do get to do that. But it's the people that our sample describe. It's the people who are represented by the sample. Now, it doesn't necessarily have to be identical, and I want to be careful here. Remember, your sample is not everybody in the population. The idea is it's a random sample of the people in the population. It's representative, broadly speaking. So there's a bit of leeway there. Your sample's never going to perfectly represent the population. That's not what I'm saying. What I'm saying is that this sample doesn't even closely represent the population of Americans. And again, think physically healthy 18 to 24-year-olds, I believe this was, physically active in a military installation. Like that's not a representative sample of the country at large. Is it a representative sample of some? Yes. Could it have implications for other settings? Well, actually, it'd be interesting to have this be applications for like sports clinics at universities who address this. So there's definitely some populations this can apply to that this might not actually be a representative sample of, and I'm just using that based on the description of who we're working with. Young, athletic. Okay, well, if you're in sports at a university because you'd be young, you'd be active, maybe this works for that too in terms of a sample. It doesn't really work for the sample of doctors. Notice they didn't tell, it's just whoever's working at the installations at the time. The 24 physical therapists and the 24 physicians, or 12 physicians. So it doesn't discuss that. And so that might not be representative. And I guess that's who we're really evaluating, is the physical therapists and the primary care providers. But the sample is, this is a tough claim. It's a tough claim, but it's one that everybody likes to make. Again, it's important when thinking about these types of claims to really contextualize what population did my sample represent. And again, can you expound on that a little bit? Yes, but realize you're walking on thin ice and just treat it accordingly. Remember our ATOM recommendation, ATOM, openness and modesty. Be open when you're walking a little bit on thin ice. Hey, I think this could refer to sports groups at universities, but that's a little bit of thin ice. That this widespread adoption of imaging privileges, enhanced capabilities to frontline providers, yikes. Yeah, that's just not supported here. I do call for additional research, but in other body regions, which is pretty funny. So that's true too. Like that's another generalization they make here, is they're saying imaging privileges, not just for low back pain, but they only studied this in the context of low back pain. So this one they did call out, and I'm glad they did, because I missed that in my little diatribe, that they did not study other body regions. So broadly calling for imaging, that may be premature. Is it premature? I'm not sure. I feel like the broad point, if the study were otherwise well designed and didn't have any flaws, might stand up to scrutiny by saying, hey, look, if it works with backs, we're just going to be a little bit more careful about how we address knees, how we address pain below knees, etc. How we address elbows. So maybe it would translate. Actually, it probably, to me, translates a little bit better to other body regions than it does to other installations. All right, so let's keep going down. MRI findings, those who receive specialist referral. So I thought the specialist referral was interesting, 16% in primary care. So clearly they're not counting the individuals who were referred to physical therapy, which was greater than 50% were referred to physical therapy. Again, it begs the question, what's going on here? And our authors would have us believe this is just PT's way better, and maybe it is. My point here is just that's not quite clearly argued, and there's been a few things that we've kind of glanced over a little bit, just assuming, it doesn't really matter that one's 7 months of symptoms and one's 3.5 months of symptoms. That's all fine. No clinical differences here. No diagnostic or imaging decision differences between those two sets of patients. Not statistically. So this is an interesting thing you'll see. It's beyond the scope of our class. I'll just mention post hoc power analysis. A power analysis is designed to determine the sample size needed for a study. Post hoc power analysis says what was the sample size needed to find significance in the study. And what you'll find is if you didn't find significance, the post hoc power analysis will always, mathematically, it's a mathematical relationship, tell you needed a bigger sample size. So a post hoc power analysis is a bit deceptive in the sense that it makes it, you think like, oh, well, if we'd just had a bigger sample size, because see, this additional analysis shows us we just needed a bigger sample size. But what you find after you've been doing this for a while, and actually after you study the math of this, is that those post hoc power analyses are very deceptive, because all they say is we didn't find a statistically significant difference. And that's truly all they say. It says nothing more. The claim that if we had a larger sample size, we'd find a significant difference is actually untrue. It's very deceptive. If you had a larger sample size and you maintained that effect size, then you could find a significant difference. But the problem without having a significant difference is that if you got a larger sample size, you very well may have zero effect size as you collect more participants. That's why it wasn't statistically significant in the first place. So these post hoc power analyses are a bit, they're included sometimes at the end of studies that didn't have a significant difference. But again, they're a bit deceptive in the sense that all they mean are that there wasn't a statistically significant difference in the first place. All right, several limitations. The sample comprises young, physically active individuals. Okay, perfect. Yep, may limit generalizability. You think? I'm sorry, that wasn't very nice. Yes, so this is absolutely true. This is a massive generalization of this study, or a massive limitation of the study. I'm glad they include this, truly, and this is a good thing, is that they have a limitation section that has a real limitation here. What I wish is that they would have just accounted for this a little bit more. They actually didn't make too many broad sweeping claims, which I give them respect for. Sometimes I'll read these papers and they'll have pages and pages of stuff like this. If only PTs had more imaging. This study proves everywhere PTs need more imaging. My gosh, PTs really need to be able to prescribe stuff too. Like, you know, it goes way, way beyond the scope of what happens. So here we had a little bit of that. I kind of called it out and lauded a bit on it. But I am glad they mentioned this as a limitation. It's probably an extremely important limitation. It is an extremely important limitation. 3 board-certified therapists, extracted orders, potential for source of bias. We also talked about this while reading through, and this is actually another one. Again, I'm glad they call it out, but man, this has some impacts. I wish they'd qualify their statements above a little bit more to contextualize within the limitations of the study, rather than just saying, hey, this should impact the world. Oh yeah, and this shouldn't impact anybody. Or not shouldn't impact anybody, but this is a very limited sample. As they mentioned, single military medical facility. Remember that ATOM acronym, be modest. If you're doing a study for a single place, this should probably not affect the world. This is evidence that we should continue to study this. This is evidence that we should continue to study this, maybe even in other populations, and be interested to see. All right, so PTs follow up more. Actually, they had data on this up here. PTs follow up more than PCPs typically do. Now, this is visit to imaging, but they describe in text down here that this visit to imaging is because people go see PTs more often. I know when I go to a PT, very rarely do they tell me, okay, well, you know, we'll see you again in 6 months, like my PCP might if I went in with some low back pain. They'll tell me, okay, we'll see you again 3 times a week for the next 5 weeks. So that's a good point too. And again, this is even more of a point. We called this out earlier. They don't call it out explicitly here. This is even more important of a point because remember what the unit of analysis is. We talked about this at the beginning. The unit of analysis isn't patients. The unit of analysis is visits. So when we have PTs having patients with 2, 3, 4, 5, 6 visits per patient, that person is absolutely being double or triple or quadruple or quintuple or sextuple counted. And it's happening much more presumably for the PTs, again, given this limitation that they acknowledge. So that's an important thing to mention too. Evaluation of fetus and extraction. Okay, 2 separate data sources. We talked about that. Data were taken from the same time periods. You know, we kind of talked about how they mentioned that they did not take it from the same time periods. One was January 2019, if I remember right, to May of 2020. We talked a little bit about why go into COVID. And the other one was, I believe, June of 24. Or excuse me, June of 2014 to June of 2020, something like that. So that seems like they're not the same time period to me. I'm not quite sure what this is saying, but that's kind of a miss. That is actually a big limitation of this study too, is one has data much longer historically than the other. And actually, I believe this, they mention it here. Oh no, they don't mention this here. They might mention it somewhere else in this. That it was difficult to find records, so they had to go back for a while because they were having trouble finding records. This, though, is another potential limitation. I visit my PCP, and my PCP, I say, "Hey, my back hurts," and the PCP says, "Okay, well, I'm gonna give you a prescription for some meds, and you should take this, and then go see a PT." And maybe my PCP is supposed to write me a referral to the PT. On the other hand, maybe my PCP just didn't do that day. And I'm not trying to say that's a good thing. What I'm trying to say is that the point of this limitation they're pointing out is maybe some things were done in the session that aren't reported in the notes. And this is actually a good point to consider in a study like this. Conclusions. Okay, so they're just wrapping stuff up, blah, blah, blah. Again, they're going to say physical therapists, different practice patterns. PT primarily uses therapeutic exercise, primary care. Oh, and again, this is just, this is the problem when you use it as a lamp for support rather than illumination. So if you think back, they're saying primary care primarily prescribes medication. And looking at this, and again, they don't break down the joint stuff here, but if I picked one thing in primary care that happened the most often in this column, it's not medication. If I pick the one thing that primarily happened in primary care, it's the PT referral. And again, I don't know this breakdown here, and they certainly do prescribe medication more often than the PTs, according to this data set and after the filtering that these researchers have applied to it. But again, now there's some stuff about that filtering that well, you all know me, I wasn't giving them the benefit of the doubt in the first place. But if I were giving them the benefit of the doubt, now I'm starting to wonder if I should. Because now you're summarizing PCPs as people who are pedal pushers, who are pill pushers. And that's just a bit of that's actually not true. Like, this statement is factually inaccurate within their own data set. And that makes me a bit concerned about trusting the rest of the things. So this is actually a lesson here for the statistical story. So I'll kind of summarize what we've gone through. We saw a really good limitation section. The one problem I had with the limitation section is I wish that they had taken their conclusions and added a bit of moderation or modesty to them based on the limitations. Right now they have world impacting conclusions potentially with a limitation section that says this shouldn't impact the world. And again, the limitation section in this paper looks very good compared to many others that I've read. But those conclusions could be just a little bit better. And actually, they look better than they certainly could in many papers, but they could be better by being a little bit more precise with wording and a little bit more modest in the conclusions. Here in this final conclusion, though, one of the lessons is to really be careful and follow the data. Like in this particular case, in their statistical story, they're trying to wrap this up. And what they do, and this is a huge flaw, and actually a whole point, I wish we could do a whole other video on, they end up saying something that's kind of factually inaccurate and leads the reader to believe that there's bias. Now, again, I know this a little bit, and on seeing who the primary researchers was, somewhat suspected that from the beginning, but it actually has come to show itself in several places, several of the decisions made. And even if we were giving them the benefit of the doubt, as we reach this conclusion section and see physical therapists are using exercise while primary care providers primarily prescribe medications. And we actually go back and look at the data and see that's not even true. PCPs, at least in this sample that they provided data for, more than anything else, what they did was recommend a PT consult. They sent individuals to PT presumably for exercise as the main tool to address this low back pain. So it's, again, it kind of comes through, and the lesson with statistical storytelling is this. It's difficult to hide when you've got an agenda. And I encourage you when you report to not have an agenda. But once somebody figures out what you're trying to say, and if you're kind of trying to get things to say something, once that comes out, all of the other decisions in the study, even the ones that were made legitimately, become suspect. As I mentioned, I think I described in one of our previous lecture sets the whole thing about evidence. And if you kind of try to massage evidence, it's like when you hand it to the judge, it kind of dissolves in your hand. It's a bit of that here too, that when you're trying to tell a story that kind of gets your point across, but it's not the point that came from the data, it's the point that what you really wanted the data to say anyway. As you describe that, what you'll find is people start to question your decisions a lot more, and rightly so. They start to ask things like, was this whole study done in a way that was intended to demonstrate physical therapies better than PCPs? Like, what other decisions that are not reported that normally I'd give you the benefit of the doubt on, what other of those could have gone in this direction? Like some of these other things that were like, hey, that seems kind of weird, but whatever. Now all of those immediately become suspect if we believe that you're no longer acting in good faith, you're no longer trying to represent or tell the story of the data, you're trying to tell your own story and put the data into it. That can become a serious limitation. All right, so in all this, again, my article review, I'm going to be talking about the summary of the article. You'll note that in this, I read it deeply. Y'all, I didn't do a 10-minute skim of the article. This is a big assignment, and it's a big chunk of your points in the class. I expect you to put time into it. I expect you to put a lot of time into it. I expect you to read it deeply. I expect you to really consider and think about it. You're going to be telling a little bit about the story of what the article talked about. But then you're also going to be doing some reflection, saying some things, some of the good things that were helpful to your statistical story. What good lessons could you take out? And then some of the bad things. What are some things that you should maybe try to avoid? Maybe writing your results in this way, or maybe maybe trying to make sure that, again, you're telling the story of the data and following that rather than kind of coming with your own agenda behind the scenes. Because, again, that often comes through. And when it does, people, rightly so, doubt all the decisions you have. Because ultimately, this process makes the assumption that you are a relatively independent and objective evaluator. Anybody can go and find data that agrees with them. Well, not anybody, but people at this level, all of them can go and find data that agrees with them. That's not the goal. The goal is, again, not to use data for support. Use data for illumination. Let it tell you where you should be going. So here, altogether, what's my takeaway from the study? Well, I think there were some parts that were well written. Truly, there were some parts that were very well written. I like their stats section. I like their limitations section. I like the inclusion of tables. I believe in the one I have you reading, they don't have a table in there. I think one of your activities as part of your article review assignment is going to be to make a table, and it's a little bit of a pain to make a contingency table. You can do it, but you're going to have to put some numbers together from in-text and do a little bit of logical calculations to figure out what those numbers are. Again, you can do it. But I like that they already had that in here, so we didn't have to do that in here. Other things that I liked, again, I thought that their methods were interesting. I think they got pretty good sample sizes. For what they did, they do acknowledge the difficulty in getting some of the data. So within that limitation, I thought that was pretty good. And I'll be honest, this is both a good thing and a bad thing. But I like the table that they show, where they show why we lost data, where that data loss came from. I think they describe it in text, which would be good. I personally like the visual if you have space for it. It doesn't really matter, honestly, but the fact that they explain that more in depth, I mean, that was an obvious question that came up to me. And then the very next paragraph, they have a written explanation with some of it. Things I don't like, I didn't like that it kind of felt biased towards PT, and it felt like that was not coming from the data. It felt like that was coming from the researchers. Again, the data sets were not comparable. The second data set had a lot more exclusions than the first, but these were presented side by side as if they were two sides of the same coin. In fact, a lot of the exclusions could potentially explain the differences in the data beforehand. Now, this might be an artifact of that they just didn't have room to explain why the two sides were actually the same. So maybe the data cleaning procedures were actually the same within both, but they didn't say that. So this is either a study design issue, in which case I don't like that they use two different cleaning methods for the data sets, or this is a communication statistical storytelling issue, in which case I don't like that they didn't describe that better. So I'm not going to assign which one that is. I'm just going to say that that discrepancy left some open questions. And ultimately, I think the other thing that I was a little bit hesitant about is this is an observational study, and they kind of seem to make some causal claims from it. I get what's going on. I get why they're doing it. I kind of get their motivations, their rationale for it. But I also know that that this was an observational study, and the risk of observational studies, that is, that they're using groups that aren't really comparable to one another, that's a big risk. They don't really mention that a lot in text here. They don't really describe that limitation very much. They describe some external limitations, but they don't really describe some big internal limitations. And that is, again, this is an observational study. Perhaps different types of patients go to PT versus PCPs. And they didn't really ever have evidence to counteract that claim that maybe different types of patients are going to one versus the other. So it's left as an open question. And that that's something that I wish they had talked about more. And sometimes that can just be a sentence to say, hey, look, these are the comparisons we thought of to make. We thought this was a relatively comparable sample. Or, you know what, these differences were different, but here's a good reason why. They did, with the number of days the patients had symptoms, explain, oh, well, HEDIS doesn't really care about that in terms of their the measure that the HEDIS data set uses. But that's not a very good explanation. That's not, why is that not important within this context? And that was upon the authors to explain, and they didn't. So those are some good things, some bad things, some big takeaways about this study. And hopefully, and ultimately, hopefully, this is something that you can use later on, something that's going to be helpful for you in terms of what am I looking at in the article review? What are some of the things I can read for? What are some of the things that I skipped over? Again, just because I missed something, if you caught it, maybe think about how does that affect the statistical story? Does it affect the conclusions? Is it an alternate explanation they didn't control for? I'm sure there's some extras that I didn't see. Maybe it was poor communication. So think about how does that impact? Or maybe it was really good communication. Maybe it was something fantastic that they did. So think about those things as you're looking through this too. And as you're reading through your article and articles as you continue this process through class. So I encourage you to check those out. And again, I hope this was helpful in terms of giving you some training, some context, some guidance a little bit on some of the things that you can look for as you critically evaluate statistical stories.